Okay, well, I am going to open it up for questions. So feel free to come off mute, raise your hand. It's not really necessary. I feel like we all are pretty used to the Zoom thing, so it can be awkward, but we'll just go with the flow.
If I'm remembering correctly, we kind of ended our conversation a little bit around cannabis and like where everybody's at with cannabis, this feeling of like we've always, or maybe we've historically reported cannabis positivity or used cannabis as like the indicator for toxicology testing. And I just emailed Elena and Matt an article that a colleague sent me this morning that was just published about findings of when we use cannabis as the only indicator for neonatal toxicology. The gist of it was not going to be surprising to this group, but when they found very low rates of other unexpected positive results, right? Like they had a 1.5% rate of finding something else in the umbilical cord besides the reported cannabis, THC. And people who were tested based on cannabis as the inclusion criteria for neonatal toxicology testing were more often to be poor, people of color, and young ages. And so really the conclusion of this article was talking, and I can chat it in just a second, was that, really we've got to think pretty carefully about cannabis when many states are moving away from cannabis only being an open case. But we've now put a vulnerable person in contact with a system that can be traumatizing. And so they're asking the question of like, what's the risk benefit here? And in their sample, the risk of being reported was higher than the risk of any finding of harm coming to the child or to the family related to the cannabis. The harm was the interaction with child protective services and being stigmatized in the healthcare setting. And so I think that's what I was even reading this morning, kind of making me think again about, it's when we think of it as toxicology positive equals report and toxicology negative equals no report. I think that's not always in the balance of all the potential harms that the family could be experiencing. Oh, Elena, you chatted it. Thank you.
Yeah. And again, we at Child Welfare don't differentiate on substances, right? We don't differentiate on the types of substance. So, and we no longer differentiate on use of illegal versus legal, which we used to do, which was always a hot mess too, right? Like it really is the impairment and impact, right? So are there people out there, moms who are delivering kiddos whose marijuana use is directly impacting the child's safety and their ability to take care of their kiddos? Yes. And if you know that and you see that and you're worried about that, yes, please call. Like that's exactly what we do. That is the job that we've signed up for. And if you don't believe that the use impacts the child's safety or mom's ability to take care of the kiddo or you don't have any concerns for child safety, then what the new statute allows is you don't have to call anymore. And in the past, you did. And in the past, I can't tell you how many calls we used to have where, again, medical providers were calling and saying, I'm not worried, I'm not concerned, and I have to call you, right? And this hopefully leans into your professional judgment and knowing that and not having to make those calls anymore. If I don't see another question, I know there was a question that ended. I can do this one too. But I know there was a question that ended last time too. We did this conversation on what's the big deal with over-reporting? Like, so what if we call 40 times or 50 times? Like, what's the big deal? And those obviously are ridiculous numbers, right? But over-reporting is over-reporting. So, why not always report if there's ever, right, anything forever? And I will say there's a number of negative side effects for that. One, the simple one is it really taxes an overtax system already, right? I mean, it puts child welfare in a really difficult position when hospitals are calling. In this case, I'm going to keep saying hospitals, but hospitals or medical professionals are calling, reporting, saying that they believe this is happening, and we go out, and then that's obviously less time and energy we can go out on other families and do those types of things. So it overtaxes an already stress system, but also as Kaylin talked about, right? These reports they exacerbate the minority overrepresentation in our system, right? So that's another piece too, right? It makes it worse. We already know it's a thing, it's a real thing, and it makes it so much worse. And then I guess lastly, we do use history as one, not the only, but one of the pieces of information we use to screen and assess referrals as they come in, right? So if you're calling in, not because you're worried, but you felt like you had to in the past, right? Because of a positive test, but you weren't worried. That still is a documented referral, right, for child abuse and neglect for that mom-baby dyad or for that system or for that family. And if there's another referral, maybe totally independent, right? Something unrelated later on, that referral that you made is still part of the history, right? So that family. So as we're having conversations at the county level on does new referral, do we need to go out on it? It's very likely we are going to pull history and say, there's a history of somebody being really concerned enough to report child welfare, and now this. As a totality, we may end up assessing that family differently if that history doesn't exist, right? So I just kind of want to put those pieces out there that it's not a zero-sum game, right? That it definitely does change pendulums and trajectories for families.
Matt, if a family had, let's say you and I are siblings, and I had a report in the past, and then you have a substance use disorder and you are reported, if I wanted to serve as like a 24/7, we agreed, okay, I will stay with you 24/7. I'll help you take care of you and kiddo so you and kiddo can stay together. If I have just that report in my own history without an open case, how does that impact decision-making around those type of agreements?
Yeah, that's a great piece of taking it a step further, even, right? So there's no set number that yes or that means yes or no, right? There's no set number of referrals or assessments or whatever to either preclude us or force us being the counties to utilize kinship care. I will say though, if there is a report in the past, it's going to make me I'm going to have different conversations, and I may not feel as comfortable, especially in an emergency situation, right? Which is that very first placement that, again, following with the same example, my kiddos are being removed because they're not safe right here, right now, right? And it never happens at a Monday at noon. This always happens at a Wednesday at 10:30 at night, when I'm just doing quick, real high level background checks to make sure Kaylin's family is safe. If we see a referral in there, that may cause a county to stop and go, we need to double check. We're not going to place tonight. We might place emergency situation tonight, and we'll go back to Kaylin's family tomorrow, the next day, do a deeper background check on that to make sure it's safe. So that may cause a kiddo to be out of home placement in foster care or paid care for a night or two, when they maybe didn't have to be. So again, none of them are yes/no lovers, but all of them add up to different decision making and can be used differently in different counties for sure.
I would say I see that scenario pretty commonly, where I take care of overlapping family trees, aspen groves, right, where there's a lot of people who are related or in close relationship in a community, and the more of those people who've had a report, even if this person may have been in active use, but maybe now they're sober and they actually would be a really helpful support for this family. It's pretty wild. I've talked a couple times about trying to figure out if there was a way to have any kind of as we're working on putting the plans of safe care more in the prenatal period, for me, what's hard is I may think I know somebody and a family may think that they would be a really appropriate kinship provider or move in with that person. But there's not really like an easy way to pre-screen before we're in that scenario. And so I do think that's the other harm I see at kind of more of like a family and community level, is that the more of us who've had a report, whether it became a case or not, the fewer of us who are available to help our other family and community members in that specific time.
Yeah, thanks. I did see that too on, I gotta scroll up now. I thought I had it. Charity. The source says that CPS is to differentiate problem use versus non-problematic use. So we have a best practice guide going out at some point here in the near future out of the chosen collaborative folks. We, child welfare in themselves, don't use it, especially at an initial review of referrals, right? Which is kind of where we're talking. We don't use a guide per se. This is before we've met the family. We might not even know who the family is, right? We just have what the report is. We are really just looking for impact. So when you're saying like problem use versus non-problematic use, the word for us then is impact to the child, right? So whatever you're seeing, if you can either see the impact to the child or know because of your medical history and your knowledge of these things, this is going to impair mom's ability to parent this kiddo. This is impact the kiddo being, get their food or be consoled or be put someplace for sleep that's safe. Or if you have that idea and have that feeling based on test results or what mom has said or whatever, we wouldn't call it problematic, but we would say there's the impact we're looking for, and then we would probably screen that in. Right. If we have troubles making that impact, if you're having problems making that impact to the child, then we probably are also going to have difficulty linking that use to impact. So I don't know if I answered your question, Charity, or I talked around it. I'm pretty good at both. So
I think this is not, so problematic versus non-problematic use in my mind goes to like use DSM-5, like use disorder or not use disorder, right? And for me, the main question around cannabis is like, do you want to stop and you just can't stop? Or do you actually feel like this is not the right time for you to stop using? And it's not that you can't stop, it's that somebody has told you not to use, but you actually have weighed that evaluation in your mind and decided that continuing to use is the right choice for you. And so, and how that shows up, I think, in roles, right? One of the criteria for like use disorder is not fulfilling role requirements, right? So like parenting safely, getting kiddos to pediatrician appointments, getting to work if you have a job, right? Like having the use of that substance impact your ability to function in domains of your life. But then I think still kind of, if for all substances, right? Like really making sure that we're clear about like, is your goal to stop and you've tried to stop and you just can't stop on your own? So you need help and support to do that? Or are we just kind of talking at different, like we're just talking about two different things? Because I think that there's a lot of assumption around cannabis that like, if I tell you to stop, that you will internalize that this is a bad thing and you'll want to stop. But I think that's different than a lot of other people with other substance use. I don't have the same, that's not the same type of conversation that I have with folks very often around like fentanyl use or methamphetamine use or alcohol use, where folks really would like to stop, but have been unable to do so on their own. Whereas I think we do in this space bump into more people who they are not concerned about their use of cannabis and feel like it has not negatively impacted their ability to do the things that they want and need to do in their lives. So I think just being sensitive to that discussion point too.
yeah, thanks, Doc. Looks like we had a couple of questions here on the proliferation or potentially enhancement of minority overrepresentation in our system by including critical thinking and giving more degrees of latitude to reporting. So I mean, first of all, like it took us 10 years to get to this wording, right, in the first place. And I think 10 really productive, solid, a lot of work from a lot of different partners to get that statute changed to this level of wording. And I think there was always the intent of trying not to increase overrepresentation, even from early conversations, right? We don't want more minority overrepresentation in the system, right? We don't want to create a system that has more of that in it. I hear the concerns. I definitely do. This language has been in now for, I don't know, what, 2 years, 18 months? With COVID, I don't even know anymore. 4 years? I don't know. Forever? 10 minutes? I think it's like 18 months or 2 years. This language has been in. And we haven't seen an increase in minority overrepresentation coming in from substance use disorder. Also, the data gets really weird with this population anyway, meaning we get a lot of referrals for infants that don't meet the definition of substance exposed newborn, but we screen in for something else, right? So I think there's opportunities for us to kind of look at this information differently. I think there's opportunities for like anything else when we provide latitude to professionals to have more more disproportionality, right? So if we're serving folks that aren't like us, I think it's easier to just see issues or problems or concerns with whoever the them is versus the us. And we haven't seen that come to fruition yet. I think it's always something worth keeping tabs of. I also wonder too how much of this is looked at internally through each hospital itself or hospital system or medical system, and the full patient population in which you serve, right? And the numbers that you're calling child welfare on, they look the same? Because I'll bet you they don't look the same, right? Or even just testing in general, I bet they don't look the same. So I think there's opportunities too for internal conversations in smaller systems pieces too.
Yeah, I really appreciate these comments about how asking people to have more, how increasing the subjectivity of our reporting actually puts some people at greater risk. And so I think this is where being very clear and honest with ourselves that by not having a positive toxicology equals I mean, there was still baked in racism to toxicology positive report, toxicology negative not report, right? But I think keeping front of mind that we're working in a space that historically has been designed to perpetuate racial stereotypes about what parents should look like and what good parents should look like. And yeah, I think it's and a lot of us work in hospitals where we take care of a large number of people of color. And so it's, I think sometimes we think oh, well, we take care of a large number of people of color, so we're less likely to be affected by systemic racism. And I have found that to be not true at all. And so I think keeping that open discussion about, really let's be clear with ourselves about the risks that this family could experience and the harms this family could experience if we aren't incredibly judicious. But I don't think we're at the point where we have any kind of evaluation or system that will eliminate racial disparity.
I also like the locus of control for change to be at an individual level rather than taking it away from the systemic level, right? And the fact that we're having these conversations means we're thinking about it. And that's exactly where I want all of us to be as we're doing the work, and we are the ones thinking about it. If we're individually running this through our own filter of would I make this report on Heather and Sarah and Shannon and right, on all these folks, or am I just going to make it on this one person? If we're doing that, the locus of change is really personal. We can have a huge effect versus having it as on the larger system, meaning just A equals B equals C, and it totally takes out any of that personal critical thought. So I like moving it in the direction in which we are, and it's a lot more personal work, right? Instead of just being able to say the system made me do the whatever or not do the whatever. These are good conversations. Next time, I'm not doing the follow up. Next, I want all easy questions. These are all making me think. Cool. I was talking about a policy in writing about not requiring all reported THC use to be So this was changed in statute a couple of years ago, and we had a really diverse and well attended community member group kind of get together on this. So in the past, and this is around the statute specifically related to child abuse and neglect. So this would be Colorado Revised Statute 19-1103 around this, which defines what abuse and neglect is in Colorado, right? I think at the crux of the issue for a long time, we were having conversations of THC or value specific or which drug is a medication versus a drug, and schedule, federal schedule for 1, 2, or 3, these types of things, and which makes it really easy, by the way, because it's like if positive for a federal scheduled 1, then you have to, right? And it just didn't work, right? But it was clear and it was easy. And now we've worked really hard for about 10 years to change that. So now 19-1103 no longer requires a report to child welfare solely based on a positive test, and not just THC. We don't list substances there, right? But language on there really reflects the language of Federal Era Act, really talking about impact to the child. So yeah, that's where I'm talking about that change. That sort of occurred. I know Heather and a few other folks. I keep picking on you because you're off camera, Heather, so you might never go off camera again. But we're part of that group in camp. We had a lot of people there, I think, with really diverse interests, and I don't think anybody left with like, this is the answer, but we left with, this is way better than what we had. I think all of us kind of left with like, this is moving in the right direction. So yeah, that's where we're at currently. Hopefully I answered that question.
Yes, you did. Thank you. It makes me feel crazy to hear that it's been so long and yet things feel about the same in my day-to-day work,
Yeah. I think there's a lot of fear of letting go of, I think there's a lot of fear in letting go of the toxicology. I think that's it. Is this test that we've kind of like put on a pedestal of like, this will tell us everything we need to know, is just like a really crappy test. And so, and even when we kind of identify like, hey, this is confirmed, this was in the umbilical cord, there was some cocaine exposure during this pregnancy, I think there is just a lot of fear of letting that toxicology be what it is. But I will say the way that this, I liked your question that you were asking about, like, who was saying like, what does this actually look like when people are reported? Who just wrote that question?
Yeah, I saw it too. Not Holly.
Oh yeah, Erica.
Mm-hmm.
Like what actually happens? And I think we talked about that. Matt talked about that a little bit, but I think what happens is actually really personal for each family. There are some people who that report is like, it's like earth shattering, and like they just kind of can't come back. Like they're just stuck in this, like, I'm just so paralyzed by feeling like I'm under the microscope and I don't know what to do, and I'm scared to come in because I don't want anybody else to see me, and like I don't want to be on any radar. And then I think there's some people who, I mean, I think I shared like one of my patients, her emergency contact is her caseworker. Like this person has become like the most therapeutic support in my patient's life. And so I think it's really variable, like what ends up happening long term. But I think those therapeutic outcomes are long term. And I think in the immediate aftermath, it's a stress for families.
Yeah, I also think how the report is made and handled internally is huge. Like how each medical facility does this, right? If the first time the family knows or finds out that a report was made at child welfare, I show up at your hospital room or at your door later on after discharge, right? And I'm just knocking and saying, "Hi, I'm Matt. I'm with child welfare," and they're like, "Whoa, how are you here? What happened? Like, who called?" And if we're there, that is so different than right this conversation being had in the medical facility, right? Saying because of A, B, and C, I need to. Right, here's what's going to happen. Do you want to be in the room with me? Do you want to make the call yourself? Do you want to hear what this conversation is? Right, like that's the spectrum, right? And kind of like from maybe worst to I don't want to say best, but kind of most family inclusive across the board there. So I think that how it begins sets the stage for everything else, right? And many times, again, I think for different counties, they respond very differently to some of these things. And I think we do take our cues from our medical personnel, right? If the doctor is very worried, if they're worried mom is going to leave or baby's going to leave AMA, and they're making those kind of gestures and plans and having those conversations, and they're very worried about the severe withdrawals of the kiddo or something. Our response is very different than, yeah, mom's on the call. She understands, right? But the report that's been made, she's charging in a day. Here's her address. Here's her supportive people. We respond differently to those types of things too, right? And again, based on history and everything else that we have to consider. So I think even on the front end, it can look very different, set the stage for, and I would say even ongoing care then on what that looks like for mom and baby dyad. The receptiveness to continue to seek medical care, professional medical care, or child welfare care, or therapeutic care, totally unrelated, quite frankly, to the substance use in general, and just trust in systems. So, Erica, I don't know if I answered your question. I'm sure Kaylin did, but I don't know.
No, I think Matt, if you want to run through like the actual, just kind of briefly, like what we talked about last time, like
the county response,
like,
sure.
Yeah, like
I think from
and what happens.
Yeah. Our most intensive response is an immediate response, right? I mean, and these are relatively rare for substance exposed kiddos. But again, if mom is saying or baby is something or having severe withdrawal symptoms and mom is talking about AMA, like leaving right now, we may end up doing an immediate response and sending a caseworker that day to that. These tend to be 5-day responses, meaning the referral comes in and a group of county folks actually sit down and map this out and lay it out in a pretty clear and easy to follow template of like, what are we worried about? What's going well for the family? What should our next steps be? And we discuss, and does this meet the criteria listed in 19-1103? So all of our stuff is based in legal jurisdiction. Do we have legal jurisdiction to go out or not? We don't get to go out on I'm worried or feelings. Like we have to anchor all of our stuff in the law. So that sometimes can be difficult. But if it does meet our criteria, right, which right now our numbers for substance exposed newborns are very one-sided, about 70%, we screen in, means we go out and see the family. About 30% we currently screen out, which again means we are pretty aligned with our medical professionals. If you're worried, we're probably worried, right? I mean, I think that tends to be what it is. So if we go out, we may meet the family in the hospital. That's always the easiest. We know where they are. They're right there. We may not. We may choose to talk to the hospital first and say, hey, we just got a call from you guys. They're discharging soon. Really, where's your level? We may call the hospital first. We may go talk to the family first. I probably did 50% of my visits then after discharge, which also, as you can imagine, is a really stressful time. There's a lot going on. Nobody gives you instructions with the kiddo. They just gave you the kiddo, and you're trying to navigate all of those pieces too. And now a child welfare guy shows up at your house, right? So there's a lot going on, but at least it's your house. So I get to see you in your house with your support, with the things that you have or don't have, and really help assess needs and that way. So that's kind of the piece. What's hard though, Erica, like for our mandated reporters, is there's no formalized feedback loop, right? Saying like, hey, Erica, thanks for the call on that family. We did go out and we were able to give them resources, and we're not going to open a case, or we don't get to say any of those things, right? You can call and say, hey, I called on this family. Did you do anything? right? And we can only really tell you, yes, we sent somebody, meaning we screened it in, or no, we didn't. There's not a whole lot else we can say legally, unless you're a different level of reporter. But that can make it really hard too, because you feel like you're kind of yelling into an echo chamber at times. So I totally hear that. I would suggest calling within a day or two just to find out if we did screen in or screen out, if you're curious, especially if you're really worried, right? Like, no, maybe I wasn't clear when I said I was worried. I made this report. Like, I really am worried. And maybe you have more info now a couple of days later. So we do all of those things. Again, majority of our assessments, we end up closing within 60 days, the vast majority, right? We go out, we assess the family for needs, we help them with what we can, we get them connected with what we can, again, based on their wants and needs for the baby, and then we're done. We close our assessment and our involvement in 60 days. Some we do open in open cases, right? And then I think the biggest number for this one to pay attention to, because I think a lot of people really worry about removals, right? We end up removing for this small set of population about 8%, which is double what it tends to be for almost everything else, right? So I think back to what Doc was talking about earlier on creating history for families and supports, right? If we do have to remove, right, really being able to remove and keep the kiddo with family, like it's just so critical, right? In all of those stressful moments when you have substance use disorder issues potentially, and kiddo withdrawing or is impacted and affected by substance use, and they are not safe in their current situation. Being able to find a safe family member to place that kid with is just so important to keep all those connections. So not creating history, when we don't need to.
Matt, can you talk a little bit about how things change, or if you've had any kind of stories told to you or observations of your own for how this goes for families if they've had any kind of conversation prenatally about like what to expect, or starting to put some plans of safe care, those components in place, versus like what I think of as like the sneak attack, which is like, those of us who work with folks with substance use can have a sense of people who are more or less likely to be involved with CPS at some point. But I feel like we should prepare everybody with like, just in case you end up talking, because I can't control what every single person who meets you in the hospital is going to think,
Yeah. The same way with history, right? Like there is no like secret bullet here, right, for any of this stuff. But I would say one of the things we also have to look at is family supports and positive family strengths, right? When we're assessing a referral, right? So what we really believe is a huge advantage of plans of safe care going forward is it creates this document pre-birth, right? Hopefully, right? It is a prenatal document of this, like I am continuing to use, or I'm in some stage of change, right? And I'm working on whatever I'm working on. But here's the plan, right? What if we've thought about this? Ideally, we've contacted those people, right? And say, I'm going to give birth. Can you be there for the first 2 weeks? Can somebody else be there next 2 weeks? Can somebody here's what I think I need, and having all of that. We absolutely do imagine scenarios in which a report is made to us. A plan of safe care has already been created. Those supports and the structure has already been in place. So we believe it's actionable, right? These are realistic things that folks can do. And we may be able to not accept or screen out referrals based on just the creation of that plan of safe care. It's a really changing component to some of this, right? If we have thoughtful discussions and good support in place, mom may continue to use. That may be a thing she's not in a place of change yet, and that's there. And I have safe, sober, attentive caregivers who can meet all of the baby's needs. So I might not have that impact, right? Because we've had these conversations so far in the past. And the disadvantage to what you're saying is the sneak attack approach, or the 5 or 10 years ago child welfare approach is I'm just starting to have the conversations now in the moment, right, with a lot of this, because we didn't have these systems or these plans. That wasn't a thing. So, moms scrambling to try and create and find support people who are easily accessed, right, and need time to help generate and mobilize and get where they need to get to provide realistic support. And those types, and make plans for what that's going to look like. And if we're making those plans 6 months ago, right now I can put them into place versus making the plans in the moment takes time. right, to get that in and get that mobilization going. So that youth may be out of the home for a period of time in the past until the support could be there. But now we've already made the plan. People are already in place. Not only are we not removing, we may not have to be involved, right? So I think having these conversations in a way is so important, but also the fact that you as medical professionals are having them versus me as child welfare. The messenger matters, right? Messenger, even if the doc and I are saying the same thing and we say the same words and we talk to the same people at the same time, let's be honest, I'm super scary. She looks super nice, right? I'll do what she says, but I'm not gonna do what this guy says, right? Um, it does. Our badges look different, and the things that the fear around our jobs is very different, and the understanding of potential power looks very different. So, yeah, the messenger matters a lot too.
I think the thing that I've started doing that for the people natally that I'm hoping is kind of helpful is signing a release for the like signing a release of information that just says like Denver County CPS, like abroad, with my name and contact info and giving that to my patient or putting it in their medical chart so they can like pull it up on their, phone and the MyChart app, so that they're not trying to scramble in the moment of panic and be like, but I see this doctor, I don't know, she's at Denver Health, right? Like that kind of moment of just like, there's so many things going on. And so I really think this is a way that we can tangibly show up for people in a system that sometimes otherwise feels kind of nebulous, like we're not exactly sure how to navigate it as a healthcare provider. But I love getting a call from someone's intake case who's like, hey, I just met your patient. She gave me this release of information. And now I'm emailing you or calling you on the phone and let's like talk about it. I think that's been really helpful because sometimes I think we hear this like prenatal plan of safe care, and the plan of safe care can be a lot of things, right? We may not know a lot of those things ahead of time, like who's baby's pediatrician or things like that. But we can identify points of contact who can really give some information about this person's progress, their treatment, what our plans are. And I think that's gone some way. I don't know if it goes a long way, but it goes some way.
I will say too for child welfare, just the taking away the veil of secrecy in a lot of these conversations, and knowing mom and caregiver are willing to engage in these conversations, even with medical personnel and those types of things, right? That starts the conversation at a very different place, right? Then yes, no, he should. She said, now I need to take another test to confirm the last test, or something. It becomes a very adversarial relationship, and it can be. And therefore, I think far less fruitful in long-term support and safety.
Yeah. Do you think, I don't want this to just be like me ask Matt all my questions. I've been wanting to ask Matt. So please, people jump in. And Charity, thank you for sharing. There's a lot of really good resources, both on the National Advocates for Pregnant Women website, the Drug Policy Alliance website, and then the Perinatal Harm Reduction website, like a association, organization website about helping people know their rights. Because I think that there is, it's an invariably like incredibly power differentiated relationship to be like parent reported to CPS and like CPS. And so just people knowing a little bit more about kind of their legal rights, resources that are out there. Elephant Circle could speak to this. You guys can speak to this better than I can, about kind of the supports that are out there for folks. But Matt, my question was if people like maybe how that feels to social services, if they do have like a sense that this person, even if they have ongoing use, is connected to some kind of support system, some kind of team, some kind of treatment program. Because what I tell my patients, and I think is true, is that even if we don't achieve complete lasting sobriety, like before this baby's born, being engaged in some form of treatment and being connected to some kind of treatment provider, some kind of behavioral health group, is a positive. Whereas I think sometimes people feel like, well, if I'm connected to Dr. Klie, then maybe that's admitting that I have a problem, right? Like there's kind of this dichotomy.
It is. I think in the past, again, because there was so much secrecy around so many of these things, like any little leak was was looked at as a weakness, right? And I think now, especially if we're getting to have much more open dialogue on some of these pieces, right? And knowing that I may not be looking for complete sobriety, meaning child welfare, might not be looking for complete sobriety. We've kind of changed that. Right, because in the past, again, positive test, I don't care what the level was, right? I don't care. Positive is we come out and we do all this stuff, right? And I mean, there's false positive. There's all kinds of issues with these other things, right? So we know that I think the medical model has been pretty well incorporated too for substance use, right? It's not getting rid of this. You continue to choose this piece, so I continue to choose to use or these things, but acknowledging that there's an addiction piece and a medical piece to this. Also acknowledging a want and desire to change at whatever level. That really helps make change the conversation. And even if the answer is I'm not willing to change, I'm willing to have the conversation. I'm willing to bring in support to help keep my baby safe. I'm willing to take action, right, to keep child welfare out of my life and keep my kiddo safe. But I'm not willing to change my baby. Even there, right? That's okay. Right, like just kind of changing our focus from the use itself to the parenting, right, and the keeping the kiddo safe. And again, I'm not saying we're perfect. I have no doubt there's an open case right now where I might look at it and go, "Oh, we're focused on the use and not the safety." I'm sure there is, but we are trying to change the system to be much more directed that way and get our families connected with resources that meet where they're at, right? And if total sobriety isn't the goal, but something else maybe, or quite frankly, if the use is a symptom of something else, larger or something else, then let's get connected with a therapist or with something that isn't going to address specifically the use, but the side effect is, right, I don't feel the need to use anymore because I'm addressing my trauma or I'm addressing my history that way. So I think we as a system are much more open to that. And yeah, it is all looked at favorably. I mean, it really is. Being open and honest is in the child welfare system, I think, is probably one of the most important pieces, because again, it's one of these things that if we start seeing lying or if we start seeing some of these things, withholding of information, then it just looks suspicious to judicial partners or whoever else may or may not be involved. And I know it's hard. It's really hard to be totally open and honest with a stranger when you're really worried about being that 8%. I get it. I really do get it. But yeah, any little degree of movement there helps for sure.
It was
I'm
just
sorry.
comment. Oh, sorry. Go ahead.
You were looking on. So Matt, I've been in and out of the call, so I apologize if I am repeating a question, but
No, me too.
can you talk a little bit about like how you partner with families? Because I think we really spend too much time, and I think our patients sometimes do too, seeing child welfare as like this evil empire when, for people that have spent their careers doing that. But I think the point is like, you guys can really help a family.
Yeah.
Here in Garfield County, we have other opportunity, there are other options rather than just, a dependency and neglect case. I think that there's ways that the child welfare system really supports families and can help them, as you're saying, kind of figuring out plans and like safety. Like it isn't really all about, it's not all about dependency and neglect and removing your kids.
Yeah, great point. I would say if anybody hasn't worked in child welfare, especially in the last 5 years, and they're saying, "Oh, I worked in child welfare for this, for that, I know what's going to happen," you probably don't. right? You probably don't. So anything longer than 5 years ago, our system continues to change so rapidly. And this is the direction specifically in which we're heading is family voice. And not just at the policy level, bringing family voice into there, but family voice for the specific family that we have, right? So I want to say 8 years ago, we implemented family engagement meetings across the state of Colorado, right, to really to formalize and put in procedure that we do. There are points in a case or in any involvement, and we have to bring the whole family in to have a conversation, right? It's no longer about mom and baby dyad, right? That may be it, but those supporting those folks act within a larger system. So bringing those usually supporting folks in, and how can they help, right? How can we tap into that? We also have differential response as another way, right? And instead of trying to catch folks doing a thing, being much more proactive, calling the family first and letting be prepared for our visit. Like that seems shocking to a lot of folks, but in most counties, the vast majority of the assessments, even substance exposed newborns, are FAR or differential response type responses, meaning the caseworker calls the family first and they say, hey, we got a report for child welfare on A, B, and C, and we have to come out, but when works for you? Now, you don't get to schedule 2 months out. Here's our window, but what works for you, right? And we used to be so worried about catching somebody doing the bad things. We could go to court to do the thing. And now, yeah, we're coming to homes, and guess what? They're clean and they're vacuumed. Because what it would be is if you came to my house, right? You would not just show up, you would call. And let me promise you, I have a 9-year-old, I would need to vacuum, right? And it would. And that wouldn't be looked at as a bad thing, right? Like I'm not hiding the normal dirt that's at my house. I'm just being prepared for a guest like I normally would, right? And actually that shows a lot of strength, right? to be able to get it together, to get the vacuum, to do the work, to clean the house, for the caseworker to show up. That's not nothing, right? So I think and then you can have your family there, right? So going back to that family-driven, assessment and casework if we have to open a case, right? But yeah, I'm saying I'm going to be here Monday at 8. Bring your family, bring anybody you want, right? I've had family visits with like 30 people. It's a lot of people. It takes a long time if you bring that many folks, but it does show something, right? That you can rally the troops. So when I'm talking about impact to the child, and you show up with 30 people in your home for the home visit, well, that speaks volumes, right? That really does, because maybe you're right. You're not in a place to make that change at the time, but they are. Right. And out of 30 folks or whatever it is, I can find somebody for every day of the week, and I can find backups. Right. So my comfort level with leaving that kid where that kiddo is really great. Right. So those are just a couple of opportunities where we make sure we have in policy to get families involved from the beginning. Yeah, thanks. And fatherhood engage the other piece too. And that's an effort we keep talking about mom baby dyads. And as a dad, I always feel left out. Like, what about me? Like, I'm there too, right? Like, I count for something, and we tend to we didn't talk about dads the last time we did this. We just brought them up now, but they're important pieces of the family, whether or not they live there, right? And maybe I'm the best dad in the world. My parents are pretty good, right? My sister's amazing, right? And there's a whole nother set of connections there that we may be able to tap in, even if I'm not where I need to be either at the time. So, yeah, thanks for bringing that up, Barb. And Garfield's doing great work around that too. Charity, I love where you're going with this too. So I also, one of the pieces I oversee too is our Family First prevention resources for Colorado, and looking so far outside of child welfare. What are the things that keep families from ever entering child welfare, ever being notified to child welfare in the first place? And if they are, then what are the things we can help connect families to so they never become involved again, or they don't penetrate our system that deeply? And really working with community providers and things totally outside of child welfare is key. Trying to figure out funding for those things, trying to figure out what each community needs, right? 211's a great resource, and there's many others. And we're actually having those conversations internally. Is in the past, we used our messaging for child welfare hotline was like, if you worry about anything, call us, right? Like we were getting calls for everything, right? And not, we'll take them. We're not saying anything else on that. But if I know Heather has an issue with her kiddo, but it's not impacting child welfare, she just needs help getting connected to a therapist, right? Like I'm not worried about child welfare, but she has a kid and she just needs a therapist, or she just needs resources for rent, or she just needs something. I think we're trying to message that there are other agencies better prepared, better equipped than child welfare to handle those. Now, if the mental health that Heather is experiencing and that issue is impacting her being a safe parent, then it's us for sure. But I think it's really in the past we end up being the default, and I think now adding another thing saying maybe we shouldn't be the default, for all things, and which is good because we can't do that, and that's not our job. And yet the family still needs something. So how do we make that connection there? That's a great point. Thanks, Jerry.
We have a few minutes left. So if you have any questions, get them in now.
You know, I know CDPHE has a child welfare, like a video training. Is there something like that in the works for kind of this updated change, or anything we could direct other staff to in our systems?
I think you're kind of asking the same question as Lauren above, where it says, what is the county's, or what are the county's multiple plans to reconcile the change in the children's code and the law change with like dissemination of this information into hospitals and caregivers, like knowledge base.
Yeah, and I think there is a plan of safe care training. It's a video, it's a walkthrough that's on. I'd have to dig up the website, but I can get it to somebody. Yeah, so and that's for anybody, right? That's I guess through CWTS or something else. But like, what is the plan of safe care and all of those pieces and the changes to legislation? That's been utilized a ton, free to the public. Anybody can look at it. I don't it's that long either, so I think it's relatively digestible. It's not I don't think it's an hour sit. I'm going to say 20 some minutes, if I remember correctly. But we issued that when the legislation changed, so we had that piece out. Yeah, I don't. And I saw the question from Lauren. Yes, this is tough info to get out. Like we did a media campaign when legislation changed. We added the trainings to folks, and then it's kind of out there, right? It is part of the mandated reporter training, right? Some of these pieces, this change is reflected in that. So if you've taken that in the last 3 years, that is in there. But yeah, it's tough to reach all of our folks who are making the reports for sure. Mm-hmm. And knowing that our counties tend to do their own county specific trainings to either hospital staff, medical staff, their schools. Each county tends to do their reach out to those folks. I'm sure they would be happy to provide that training for sure.
Yeah.
Matt, you might also want to talk a little bit about Support Colorado and the work the state's doing with Illuminate to get information out to providers.
I totally can, but also, Shannon, since you came off mute and you made that bad decision, and I introduced you in chat so folks can see your face, there you are. So Shannon is our new substance use disorder, substance exposed newborn specialist at the state. Shannon, do you want to share with them the work that we're doing with Illuminate?
Sure, but you may have to correct me if I miss a couple pieces. But I think, Lauren, the struggle you're talking about is a struggle that we're also trying to navigate as a state agency, and we're really trying to work with other state partners to kind of get the word out to help increase that education and knowledge piece. So Illuminate, they have a collaborative called Support Colorado, and within Support Colorado, there's actually a provider education work group, and their goal is specifically to expand healthcare provider education owned not just the topical area about perinatal substance use, but then all these pieces we're talking about around like plans of safe care. What does that actually mean for providers as as mandated reporters, and how do we make plans of safe care, and what does navigating these pieces look like? It's definitely still in the works. I think because everything is so different for each community and so different for each county, that's going to be part of the long process, right? Is really making sure we're matching the needs of your communities, the knowledge needs, the information to what we're doing. And I think the role of the state is to support that work, to support our county child welfare departments with connecting more to their primary care and the FQHCs. So I think your struggle, again, is something that we also are struggling with, and we're trying to navigate, and we're working with some of our state partners to fill in those gaps. I would also recommend looking at, I think it's the Chosen Collaborative. They are hospitals specifically who are trying to kind of look at what is best practice around these changes, and how can we get the information out, and how can we support families. So those are just a couple of the things that we're working on to really try and expand and improve that knowledge and information. Did I miss anything, Matt?
No, per usual, you did better than I would have. So thank you.
I think also, I mean, not to be like a jerk, but I mean, I feel like if you're on this call, you are interested, and like, you're probably the right person to like go forth into our our respective realms and really be the change agent. All right. And open up, like, I just learned that, did we know a couple of years ago this changed the laws about required reporting and things like that. And so I don't want to say like, you have to answer your own question, but I do think each of us has a responsibility to share this information with our respective organizations and hospital systems, if we have, if we're working inside hospitals particularly, so that people can catch up, right? I think that there has to be some kind of like, a lot of practice change actually is like word of mouth, right? Like, I'm doing this now, and this is kind of how I've changed my practice. And so people learn from each other. So I don't know, I think we all are probably part of the information dissemination too, but I do think that Matt, from like a state and county level, being able to maybe again, like maybe maybe it's been enough time since the initial rollout to like kind of do another campaign.
Yeah, Shannon and I were chatting about that earlier. She has been with the state for all of a week now, so please just hammer her with emails as much as she doesn't even have an email address, so that's fine. But yeah, I think we've had these similar conversations. Is we are in a new phase, and that website I posted on with Plans of Safe Care was from a 1-day event we did do with Plans of Safe Care right after the legislation changes, and that happened right before COVID. That was March of COVID, whatever year that was, right? And a lot's changed, right? Like for a whole different place. So, yeah, this may be something that we look at to show kind of a state of the state where we are now with some of the stuff and direction to move forward. So, thanks all.
Yeah, thank you both for joining us again. And I will be sending out this recording, and as well as Matt and Dr. Klie's emails. So if you have any further questions for them, feel free to email them. But it was great seeing you all again. Thank you for those who came off or came on video. And we hope you have a great rest of your day. Bye, y'all.